Hey, folks, imagine this scenario. Your patient is crashing, the ventilator is maxed out, the O2 saturation is falling, pressors are climbing, the blood gas looks worse every single hour, and despite everything you're doing, the patient is still dying in front of you. So, what happens when conventional resuscitation isn't enough? And at what point do you stop asking, what else can I give, and start asking, do we need to replace the function of the heart or lungs entirely? And that's where ECMO enters the conversation. Over the last decade, ECMO has evolved from a niche rescue therapy into one of the most powerful tools in critical care and resuscitation medicine. It's changing how we think about cardiac arrest, refractory shock, and severe respiratory failure. But ECMO is complex. It's resource intensive, it's high stakes, and not every crashing patient is a candidate. So in this episode of The Learning Curve, I am joined by one of the leading experts in ECMO resuscitation, my mentor, the man who scolded me into the doctor that I am today, Dr. Hitesh Gidwani. He is one of the ECMO specialists at Methodist Hospital, and he is going to break down what ECMO actually is, when should you start thinking about it, how it fits into emergency and critical care resuscitation, and most importantly, how do you recognize the patient who may benefit before it's too late. Gids, thanks for joining me today, man. I really appreciate your time. This is going to be so fun. It took me a long time to get you on, but I finally got you.
This is my post-call face, in case your listeners need to know why I'm looking so disheveled.
No. This is his face after he climbs a mountain in Argentina and survives with an O2 sat of 50%. He told me the story, and it was definitely one of the most incredible stories that I will not share on this podcast episode. So let's get right down to it, which I think this is a fantastic segue, refractory hypoxemia. All right. So, Gids, let's start at the basics and just kind of set the stage for this conversation. When we talk about ECMO, there's a certain mystique about that word. And again, over the last couple of years, it's gotten a little bit demystified, but let's start at the basics. What exactly is ECMO? What are we talking about when we drop this, unique word out in the universe?
Okay, so, I think you and me have worked together, so you see this reality that it's this word that you say at the end of everybody's conversation when someone's dying. It's a magic word. The short of it is, we've been doing this for about 50 years. I think the first ECMO circuit was 1970. So we're not talking about something that is new. It's extracorporeal support both for either your lungs, your heart, or both. This word salad that we play with ECMO now used to be VV for your lungs, venous, VA for your heart, arterial. Then now we added more word salads. So VAV for both heart and lungs, VPA for just your right ventricle. And I think now the word salad gets bigger and bigger because the circuits get more and more refined. But the crux of it is either extracorporeal support for your heart or extracorporeal support for your lungs, depending upon the situation. And then obviously there's more to it. But when you look at it from a basic stand of view, most of it has been essentially rescue therapy when things cannot go your way, with basic stuff. You do your basic respiratory failure algorithm, you do your basic card shock algorithm, and you reach the end of the line, I don't know what to say, then the word VA or VV ECMO comes about.
Perfect.
Fair?
No, I think that's actually a fantastic overview. And this is where I'm really hoping that you can shed some light on some of these concepts that we're talking about. And I think one of the biggest misconceptions that I hear from a lot of people, and I wanted to get your thoughts on, is people think of ECMO as, hey, this is a cure. This is going to fix the problem. This is going to, fix our ARDS. It's going to fix myocarditis. But from your standpoint, one of the, I guess, more refined explanations is, hey, this is more of a bridge. Can you explain that more in detail and kind of what that entails?
Yeah. So let's break it down into pieces, because I think if you look, you can't look at them as one single treatment arm. So I think let's go with veno-venous, because that's more data-driven compared to veno-arterial, and we'll go through it a little bit more in detail. So veno-venous is basically lung support for refractory ARDS. That's the starting point. Done essentially depending upon where you are in the country, early, late, rescue, and then depending upon where you are in the algorithm, you have not done a rescue therapy, you're not able to do certain therapies, patient is not obese. There's so many variables to this. Starting from the top, we'll go with what guidelines tell us, because that's a good way to assess. Because honestly, guidelines are about 10 years away from what we are actually practicing today. So where do the guidelines land? So let's start with VV ECMO. It is done for refractory hypoxemia or refractory hypercapnia or both. Most of our algorithms start with using the PF ratio, which is PaO2 divided by FiO2, and that tells you the severity of the illness. Now, when you look at your disease processes, we try to say a PF ratio, and I think most places are settled on a PF ratio less than 100. If you look at the guidelines, they look at a PF ratio less than 80 for more than 6 hours as your inclusion criteria right off the bat. You have to basically be early That's relative, less than 7 days in your disease process. It's usually predominantly pulmonary and not extrapulmonary. So what do I mean by that? You can't do ECMO for pulmonary edema, right? It's treatment. So it has to be a primary lung injury or a lung injury in the setting of sepsis. And those tend to be your crux of what inclusion criteria tends to be in ECMO for lungs. Early, refractory hypoxemia, and obviously refractory hypercarbia. And I think it was 7.25 or less on your pH and a PCO2 of 60 or more. It sounds very technical and I'm saying all this, but just understand it's just refractory nature. Now, when you look at it from a VA, which is the cardiogenic component of it, I think a good way to understand it is not specifically using these magic terms like cardiac power and amount of pressors and all that stuff. For your listeners, I think a good way to look at it is the SKY criteria. SKY basically did A, B, C, D, E. If you look at the PE criteria from this year, same thing. At risk, beginning, sliding, and then in extremis. Sounds nice, but gives you a very simplistic way to assess someone's disease process. So in your SKY D or SKY E, card shock, low flow state, rising lactate, not improving, peri-arrest, that's when you start considering VA ECMO as a bridge to recovery. Obviously, in situations where you have reversibility. That's a Pandora's box when you look at what we define as reversibility and patients when we get called for them. So that's V and VV. And then obviously there are little bit side extensions. So a good example will be asthma. Asthma and VV ECMO is almost like 100% outcomes if you look at it, how we do it. Same thing with refractory pulmonary embolism and VA. Great outcomes, just have to choose the right patient. That in your crux is your groups of patients that you look at VA, VV, and obviously the asthma and the PE patients. And then from my world, you have to add additional situations like post lung transplant, heart transplant, where the grafts are not working. And if you're in a trauma center, because I have a bunch of friends who do trauma, it is not even uncommon. Traumatic lung injury and VV ECMO is not uncommon. Our other world, we do a bunch of neuro cases. If you look at it from a cardiogenic shock in the setting of subarachnoid hemorrhage, acute cardiogenic pulmonary edema in the setting of, again, ICH and all these. For young patients, we do put them on ECMO, and it's actually not uncommon for these situations too. So, right off the bat, when you walk into this conversation, who can get ECMO, you can see the world is in your front of your face.
And
See, it's a lot, right?
no, and honestly, I think that's actually a great segue into that Pandora's box that you just kind of alluded to, right? And this is something where, if you're at an academic center and you have more exposure, and we talked about this before we started recording, is you might have a better sense of, all right, I think this patient potentially might end up needing ECMO. But if you're at a site that doesn't necessarily have those capabilities and you have to potentially think about, do I need to transfer this patient for that higher level of care? That's where I think some of the challenges really arise for a lot of the community doctors that are out there, whether they're emergency physicians or intensivists. But that's kind of where I was hoping to shed a little bit more light and get some of your expertise on.
Yeah.
So if I'm working at this site, what's kind of my trigger, or what should I be thinking of? Hey, this patient potentially might need that resource.
So again, let's break it down into VV, VA. I think it's just easier. So choose VA or VV. We can
Let's
pick one of
start
the
VV.
two. VV. So much common VV, understand, I think with your listeners, you all do a lot of pediatrics too, correct? For babies, neonatal distress syndrome, VV has been standard of care since 1990s. For adults, honestly, the ball started rolling after the influenza epidemic in 2008 with the Caesar trial. That's kind of where I would say the world of VV ECMO for us as adult intensivists came into the game. And, Yulia looked at what you're asking. Does treating ARDS, when you start entering this refractory nature, where you've gone through your proning, your neuromuscular blockade, your vent settings, and you're not improving, where do you draw the line on management? Should you transfer to an ECMO capable center, or should you basically keep them till they need ECMO? That line obviously has been changing every few years, but that's the starting point of this conversation. Yulia was the one that came after that, refined it, but Caesar said, and I think if you look at the data, transferring to a ARDS capable center where that's all you do did better, even if you did not need ECMO in the end. And that's kind of how we started with this hub and spoke model of community centers manage ARDS. Once you draw a line, depending upon what your agreed upon criteria, you move to an ECMO capable center. I think that's what we did from 2009 to 2019, I think. COVID changed the game for us completely. Completely changed the game for us and how we manage VV ECMO. Now, starting from the top, I think look at traditional criteria. you are at bedside of a patient, you're treating something with primary lung injury or secondary lung injury, like maybe pancreatitis, ARDS. You're on the vent. It's been 3-4 days. It's less than 7. Your patient is young, which is again now entering this world of age, and you're either prone, you start neuromuscular blockade, your PF ratio is still 100, 110, and you're wondering, man, it's been 4-5 days, I'm not making headway, my kidneys are going south. What do I do? That's the starting point of what traditional ECMO referral is. Where you draw the line on, I think extracorporeal support might be needed. We all know that lung injury is propagated by the ventilator, right? I don't think that needs any explanation. As a medical community, we just drew a line at 6 cc per kilo, right? Look at the plateau pressure trials and the tidal volume trials. We just literally randomly drew a line and said 6 versus 8, 6 versus 10. Who didn't say that 5 is better, 4 is better? We just randomly said it. So when I say tidal volumes of 6 cc per kilo, plateau pressure less than 30, these are all like arbitrary lines in the sand that you've drawn, honestly. So I'm not saying that that is saving your patient. That's still injuring your lungs, just less. So every day you're on a disease process that's dragging it on, and your ventilator is going on and on. That lung injury is constantly going in and out. It's adding to your problem. So we all know this from the ECMO world. The longer you stay on that cycle, the higher you're on this 100% FiO2 game, the more oxygen toxicity causes fibrosis. At the basic science level, we all know this. Just hasn't made it to a randomized trial to prove it yet. Same thing with length on ventilator, we know that. 14 days on the vent, you're probably going to do poorly. There's no real recovery from that. And, that's the crux. A referral starts when you have a reversible disease process in a relatively young patient who is not responding to conventional means, which you can do in every hospital in the country, right? The only thing you probably can't do in most smaller centers is basically inhaled vasodilators. You can prone, you can paralyze. Inhaled vasodilators is basically a little bit of a side on add on which you can do, but understand that there's no data to prove that pulmonary vasodilators improve outcomes, and they're expensive. So so I put everything together into this ball. Age, very interesting question. Most centers will stop at 65, some will stop at 70, we stop at 80, because chronological age and physiological age is so different. 72-year-old playing golf is different from a 72-year-old going in and out of nursing homes. We've all seen these patients. Chronological age is very hard to tag to a physiological age. Your frailty index is good, and I'm looking at patients. I'll always ask the family, hey, what's he doing on his best day? It's so easy to ask that kind of question. It's not hard. Even before you go and say, oh, Mima is basically living in a nursing home, gets fed every day, cannot bathe. Stop.
Yeah.
You understand what you're asking is a physiological insult that they're going through with their disease, and then adding another major physiological process with ECMO. Can't go forward. Next thing is going to be a BMI. To me, that's a very, very loaded question. Just for you, since I know this is a bit of a tough. What is the exclusion criteria for the ECMO trials for VV for BMI?
I'm gonna guess. Oh my god, this is like flashback. I'm going back to residency right now. I'm
I
gonna
think the
say
last
I'm gonna say
was in
I'm gonna say
2018. So
35 to 40.
45 is where they drew the line.
Wow.
So for ECMO and Eulia, which is the last VV ECMO trial, what is your average ER patient's BMI on the most of?
Oh
50,
boy.
60?
Yeah, I would say way higher.
What has changed?
Yeah.
So BMI criteria is center dependent. Let me be very clear. Offering ECMO to someone with a high BMI, the restriction is not in the fact that they are not candidates. It's basically technical. That's the relative exclusion criteria. Now, if you're a young program starting out, you're not done a BMI 70 ECMO, it's a growing pain, but you get there. Understand that BMI is a very relative criteria. There's a very good study that came out in JAMA about 3-4 months ago, and I kind of loved that when I read it. It's basically a survey of all ECMO capable centers and their ECMO doctors and their ECMO coordinators on what they define as criteria. Taking a little bit of a detour, I forgot to start with the statement. You have scoring systems that are designed to tell you predictability of outcomes in VV ECMO after ARDS, right? Your Murray score and all these SAPS2, and they all look at comorbidities of these patients, tell you their probable mortality. No one uses that. For VV ECMO, it's all center dependent on what you define, both for age, length on the ventilator, BMI of the patient, the frailty of the patient, This is such a interesting statement. So for your listeners, I always say, age for me, if you look at most centers, 18 to 80. BMI, there's no BMI restriction. BMI is just if you cannot fit a cannula, that's a restriction.
Makes sense.
There's different obesity. There's a BMI with apple obesity with a big belly, different case. There's a trunk obesity where they're tall and fat, different case. I've done BMI 70s. It's not easy, but honestly, it's not a contraindication from a patient perspective. To me, it's always been a contraindication from a technical perspective. So, and then length on the ventilator. Most literature tells you 7 days or less is when you should refer if you're in refractory disease process. And again, it's all different. A patient who is sliding for weeks and then gets intubated and on the ventilator for 7 days is different from a patient who is completely fine, gets sick and intubated after having a completely normal functioning state and is at day 9. Completely different. So I think duration of ventilator also is a very big variable because it has to include what the patient was doing before, what they are doing right now. Was the patient on lung protective Centix for the last 7 days? Was the patient's plateau pressures more than 40 for the last 3 days? Pretty different patient profiles. Starting from like what you should put as a base, earlier the better. Less exposure to 100% FIR2, the better in terms of outcomes. But doesn't mean that late is a wrong outcome. If your patient's on day 10 and has been fine, and all of a sudden we get a referral, just to give you an idea, I got a referral from El Paso, yes, 2 days ago for a patient who's been on the ventilator for 35 days. And she's been tricked. It's an ILD case with fibrosis, but she was fine for the last 20 plus days, just on low vent settings. And basically probably had another ILD flare and she's young in her 50s. How do I put that into perspective? Someone who's on lung protective ventilations and tricked and young, but now you're getting this call, hey, she's on the vent for 30 days. Most centers will say no because you look at it from a very numbers-based thing. Do not hesitate calling your ECMO capable center. Centers are very open to talking to any referral team and guiding you to what their process is because your location defines who your referral base is, right? For you, it's going to be Pittsburgh or Cleveland or maybe Buffalo because right in the middle of all three locations. So you can see if you start calling them the nuances and what these centers define as cutoffs. And I'll actually always tell you guys when you're like in your location, try to call, ask them what you want us to do. Some centers will say, man, day 8, goodbye, don't call us. Centers are very different in how they approach it. Now we're reaching once you reach 300 ECMOs a year as a center, you get more perspective on what good outcomes can be achieved, no matter who they are, depending upon this very rigid criteria that we have set forward when you look at literature. So age, BMI, PF ratio less than 100, early, that seems to be like the 4. And then you can add ventilator stuff in the sense that plateau pressures, driving pressures, all this is beyond the scope of this conversation, obviously. That's VV. What do you think about that?
That's perfect. Let's dive into VA then.
Before I go back, VV, the people that do well, if you ever have to intubate an asthmatic, stop. Before you intubate, call your center. Because you've been through this you intubate an asthmatic, one of two things are going to happen. Either they're going to be fine with the deep sedation and kind of level off with the steroids, or you can't and you're bagging the crap out of them because the CO2 is 120. I think the longer you work, whether you're in the ED or the ICU, you always want to get an asthmatic every few months that even after tubing them, you can't ventilate, can't oxygenate. And then you start seeing barotrauma, they pop their lungs. So to me, and at least in San Antonio, how we have done it, for any of our referring hospitals, is if you're thinking of intubating asthmatic, stop and call us.
That makes
sense. Because I've put so many asthmatics on as soon as they got intubated because they've been in refractory hypercapnia in the ED. It's the only time I do emergent VV ECMO. They're running to the case. And these are young people, right? Most asthmatics are 20 to 30 years of age, younger than 20. These are salvageable people that just need 1 or 2 days. You put them on VV, give the steroids 1 or 2 days to work, and they're completely fine and talking the next day. So one variable for VV was obviously the asthmatics. VA, oh my. Actually, VA is easy to talk about because, cardiogenic shock is a different metric altogether. It's most of our VAs. VV outcomes tend to be, with ECMO, your mortality is about 40%. With ECMO, without ECMO, it's about 60%. So you can get a predictable 20% improvement in outcomes for most patients. VA, cardiogenic shock has extremely high mortality, extremely high. whether post-MI, heart failure, like chronic on acute, arrhythmogenic shock. There are certain flavors with myocarditis, post-transplant, just arrhythmogenic cases without heart failure. Just putting everything into all comers, it's a very high mortality disease process. Cardiogenic shock plus ECMO, the outcomes have not been that great. If you look at the trials for VV, and meta few and then retrospective analysis and meta, we see a predictable outcome improvement. Cardiogenic shock, man. The problem is because these flavors of disease processes are so much, when you clump them into one big pool, you lose the improvement signal if it were there for any specific ones. So when we look at card shock, we look at, let's say, Sky D, which is the case that you guys should know. So Sky C is when you're in low flow state. The patient comes to your ER, patient's in your ICU, either tubed or not tubed, your lactate's going up, they're not peeing. That's Sky C. That's usually when you end up requesting maybe MCS if the patient has a reversible process. MCS is not something that's a given. Balloon pumps and Impella CPs are becoming more standard. Don't discount the balloon pump, please. I think Impella has just been pushed onto us a little bit too much. I think both have their place. Patients with severe peripheral arterial disease don't do well with big catheters. Their legs become ischemic. So there's a place for balloon pumps. The reality is that the Sky E, which is the one who's about to code in front of you, they don't have time for all this stuff. So those are your straight off the bat ECMO. Sky Ds are the patients who are already with the balloon pump or with impellers and they're declining. That's your general scheme of who to offer ECMO. The data doesn't prove all I'm saying. We had one good trial from I think 2023. They did card shock patients like this. Either some were ECP or some were just in the cath lab. Didn't improve, but obviously those trials had a lot of clinical caveats. My take home, a young cardiogenic shock, reversible criteria. Young patients don't hesitate to call when your lactate's going up, because in early MCS before ECMO, if you look at each and every center, we have good outcomes if you just choose the right patient. Who is the right patient? So, okay, let's go with backwards. Let's see. I think it's easier to go from the worst outcomes to the best. So, post cardiac surgery, cardiogenic shock, worst outcomes. If their ischemic times are long in their bypass or their valve surgery or whatever, or their aortic repair, they come out with these stunned hearts that don't respond to anything, pressors, inotropic agents. We've done ECMO on them, but the outcomes are abysmal. So if you find someone young in that particular subgroup, young people can handle this insult more than older people. That's your ECMO candidate. But generally, for me, prospectively, if I get called at 2 in the morning for a post-cardiogenic shock patient after a bypass or all this, we have done VA ECMO, then done balloon pumps and got them through it. Understand the line in the sand for you is these patients, it's a surgical, forgot to mention, these are program patients. Most patients with cardiac surgery are program patients. Shared decision making between you and your cardiac surgeon who's involved in the case. Then moving back to what you really see much more. Post-MI, such a common case like STEMI, card shock. You've resuscitated this patient, got them back from CPR. There was STEMI. You basically get revascularized and they're low flow state. Today's world, most of these patients come out with an impeller, just an FYI, because that's becoming more ubiquitous in these like high-risk PCIs when they come out from the ED to the cath lab. So you already have a device more often than not. It's not the solution. These devices are not great all the time. There's hemolysis, there's bleeding, it sometimes doesn't work, it pops out of the RV, LV, no matter where. So those are patients that you can offer ECMO as a bridge to recovery or bridge to LVAD or bridge to transplant, depending upon who they are. Same thing. Patients are low flow, lactates going up. Patients are not making urine, their lungs are more congested. That's your ECMO patient. Then look at your myocarditis cases, your post-transplant cases, some people, if you will see patients who have had a heart transplant 6 weeks ago, 1 month ago, 1 year ago, they forget to take their rejection meds. They come to you in like 3 pressor shock. You intubate them. They're still not recovering. Call their transplant center. ECMO is not at all a bad option to stabilize these patients. Graft dysfunction, good case. Young people with primary arrhythmias, we see them once every 6 months. I had like a kid who was 19 or 20 going arrested at the San Antonio airport and came to us almost 1 hour, 20 minutes after CPR, kept getting shocked into sinus and still did well, went home, completed his course. So you see that.
Wow.
So you have these cases. Card shock, easy, Sky D, Sky E criteria, which are basically just clinical criteria, good candidates. The data is not the best for these cases, but to be very frank, it's a lot of caveats because no one has done good trials. I think good outcomes exist. Don't hesitate to call. And then the last one, which is my biggest interesting case.
And this was where I was going to segue because I knew you were going to give us some hot takes. So actually, I think it's actually a fantastic segue. So let's start with what is eCPR for folks that might not be aware, and then we'll dive into some of your lovely hot takes because I think that's going to be a spicy part of the conversation.
So CPR is a part of your resuscitation guidelines, I think, with ILCOR. I'm not sure if it's the same with AHA. CPR is basically extracorporeal support or going on VA ECMO if your patient in refractory cardiac arrest is not having ROSC. That's the most simplest statement. Refractory cardiac arrest, not achieving ROSC. Do you consider putting them on ECMO as a way to get them to ROSC to treat the cause? Now, traditional criteria for most studies, and when I say most, I mean 3 studies in the last 10 years, has all included shockable rhythms. Because now, start from backwards. You and me all know that shockable rhythms do better than non-shockable rhythms, both for resuscitation, for cooling or temperature management, depending upon who you are in that spectrum. So the same thing goes for putting these patients on ECMO. Remember, when we look at recovery or what is considered a good outcome after cardiac arrest, no matter the cause, is basically neurological, because no matter how many machines we have for stuff below the neck, we don't have anything to fix the brain yet. So that's a very important statement in what we do in terms of offering ECMO to cardiac arrest patients who are not achieving ROSC. Statement guidelines. Where do you start with? Whether you're in the ED or in the ICU or on the medical floors, you're all going to go through people who will end up in refractory cardiac arrest in your careers, and you are going to be the primary resuscitationist. Guidelines will draw a line and say patients with refractory VTVF. We don't want to consider patients with PEA asystole because for the most part, their neurological recoveries are abysmal. Is there caveats to that? Sure. For you, start with VTVF. Duration of arrest time. The call to go on ECMO and to be on ECMO traditionally is anywhere between 30 to 60 minutes. So when the patient goes down, the timer starts. And when you should be able to go on ECMO, it should be less than 60 minutes from that moment in time. Now, depending upon a small community hospital or a well-to-do system where you've got multiple large centers next to you, that number changes. So from collapse to ECMO, 60 minutes or less. Can your patient make that timeline? Number 3, you've tried defibrillating them for 3 and given them amio. I think that's more. And that's your clinical criteria. We have other metabolic criteria that exist. And this is very important because the first trial was the arrest trial. I think that was just a very interesting 30-patient study from Minnesota that said, hey, eCPR can improve outcomes. And then you had a couple of European trials, which I really like. I think the Prague one was the one that you guys should read about because in terms of volume, it almost reached 250 patients, which is unusual for eCPR. Obviously, this is a very loaded question because as an ED provider, you are looking at having a very mature system where if you're working in a hospital with VA ECMO and you can call a ECMO team in your ED versus some centers like Taiwan, for example, they go to the patient. So I think if you look at countries, Paris, Taiwan, extremely mature programs where they actually go to the patient to arrest. Minnesota is trying that now. The literature's out there. Centers will have to define what is their appetite for that because it is a very resource-consuming call. So if you're a provider in the ED and you see the situation where you have a refractory VTVF, now enter the caveats. Witnessed, because an unwitnessed arrest, you have no idea how long they were down. All trials have started with the statement has to be witnessed. Bystander CPR within 5 minutes of patient going down. And then you start the timer from that moment where the patient goes down. And to come to you in your ED, I think the couple of centers said 30 minutes from going down to ED can consider ECMO. The Europeans were able to expand that and they said from arrest to ECMO in 60 minutes. So that's your basics. Age, loaded question. I think 18 to 65 is a good conservative thing. 65 to 75 is a very interesting number that, depending upon your centers, you can consider. The conversation can be both in hospital because in hospital arrests are much easier to prognosticate. You know when they go down, you know who did the CPR, they're all trained providers. You have everybody in the hospital. It's much easier to get equipment either from your cardiology team, your cardiac surgery team, or your intensivist team, depending upon where you are. Sounds very easy, but depending upon how you approach ECPR, understand when we look at what I just said, VV ECMO and VA, you look at the patient, who they are, how they're doing, what organ systems are disease process, and you can put into multiple scoring systems and get, hey, man, this is a very morbid patient, don't offer it, or this is a good patient. In ECPR, you're starting with zero. I get so a good ECPR program is a very well-oiled machine. So what do I mean by that? Whether in hospital or coming from the community, let's start with community. The first responders need to know a refractory VFib should go to ECMO capable center if you're in that environment, because that's the thing. Early transport. Not trying to intubate, keeping them on an LMA because intubation wastes time. Getting them to center with adequate information, and man, that is the loaded question right there. How many times have you seen EMS people come to you and give you a clear story of the patient? You tell me. Never. Like, oh,
It's hard for them because there's a lot of different variables going on. So at the end of the day, if they get the patient to me, I'll take that. But no, I see your point, and that kind of makes the decision making
activate.
process 80 times harder when you're not sure.
Yeah,
Hey, how long was the downtime? Was there actual
right.
bystander CPR? You don't have access to that information, so that does definitely make the decision making process significantly more challenging.
We keep talking about it. That's why I think my hot takes are going to be like, each ECMO run is about $50 to $100,000 for the system.
Yeah.
Number one.
Hmm.
You have no idea what's there. So a good example is someone with terminal heart failure goes into VTVF. The wife doesn't know. She calls EMS, does CPR. Well, what do you mean? Just touches their chest because someone on the phone tells them to do it. You and me know, right? And then when you come in, put them on VA ECMO, then you take the pants down and you see missing limbs. Happens so many times. One of my coordinators said the first thing she wants to do when we're about to start is take their shoes off because sometimes you don't see the feet. Then you're right off the bat, it's like we've put people on, we didn't do the shoes, toes were missing, bad PAD, the cannulas can't fit because the vessels are this tiny. As providers who are offering ECMO, I think getting a story, getting EMS doesn't know half the time when they got called. So our system has a very interesting way to do timings. We get a sheet from the EMS when they say, hey, I have a refractory VTVF that we have picked up from so and so. Our time for arrest is at 11:30 p.m. and we'll be in the ED at 12:05. From coming to ED to going on ECMO, each center is good. We can do it in within 5 minutes. So that doesn't offer much, but getting the story. Next thing you know, someone found them sonorous breathing 30 minutes ago, didn't feel like they wanted to wake them up. Comes back 30 minutes later and then they call EMS.
Hmm.
Who knows what the time is? Conversely, the reality of age bias. Man, if I get a phone call saying a 19-year-old is in VFib arrest, how do you have that cognitive bias to say, okay, they were not seen arresting, but is 19
Yeah.
or mother of a four. That
That's
the
tough.
bias of age is so strong. The bias of all this, the person who decides, because when you're at the bedside making the decision, yes, bring to me, I want to activate the protocol. I want to get providers coming from different parts of the hospital. And then it's a coordinated process. So the inclusion criteria for providers who are on the sidelines is, as an ER provider, I expect you to secure the airway, get me my entitled CO2, run the code while I'm deliberating the information. And then it's a shared decision making process with everybody in the room. Then comes the biochemical criteria. So age, downtime, bystander CPR are all like clinical criteria. Presence or absence of systole or PA, because so many times you'll see patients start off with VT, VFib, but then by the time they come to the ED, they are in asystole. This is all driven by the ability to offer good neurological outcomes. Things that are hard to say, the end-tidal CO2, sometimes that LMA is not in the right spot. So
Hmm.
when you intubate the patient and you say, man, the end-tidal CO2 is 35, end-tidal CO2 is 8. No. So different versions. And then the hardest part is in the biochemical criteria. The trials put lines in the sand and they looked at registry data. A lactate of 15 or more, a pH of 7 or less were the ones that had a high value, predictive value for poor outcomes. So before we even start the process of putting them on, the providers will basically get a blood gas. And we're basically, by the time most centers will have the groins prepped, ready to put them on ECMO, then we get the call, this is the gas, and then we move from either yes or a no, bit depending upon the team. So as a provider in the hospital, let's say in your ICU or on the floors, the same criteria apply. Age, Downtime, bystander CPR, is it a shockable rhythm? And then you move to the biochemical criteria, but that's when the ECMO team is already at bedside. Don't hesitate because it's a shared decision motion process.
Mhm.
We need the clinical criteria to match, and we will add the biochemical criteria by that time. Any questions about that, man?
No, honestly, man, I think that's actually a fantastic framework. And I think it clarifies a lot of things that folks out there might be struggling with. Hey, do I think about this patient for ECMO? Am I the one making this call? Who am I calling? Who's the right person to get this information from? And honestly, the part about the history, I think, is very, very key, especially for us as ER physicians trying to, just piece together, hey, how long was the downtime? Was there actual good bystander CPR, initial rhythm? What are we working with? In kind of that time frame, I think establishing all those principles, I think, is really, really helpful. So let's say you get a patient on ECMO, VV,
Mm,
VA ECMO.
mm.
What are some of the problems that potentially you might run into when they're on the circuit that you have to watch out for? You've already kind of alluded to some of them, with the bad peripheral vascular disease, limb ischemia, all these things. But what are some other things that potentially you might run into while you have them on the circuit?
Fair. Oh, easy, totally. So easiest one to start with because that's what I have to talk to families when I give consent, right? Bleeding, biggest problem because you have to anticoagulate these circuits. It's like engine oil for them. So you're running high PTTs, coagulation strategies. You can have bloodless ECMOs where they don't have even one drop of blood coming around. You can have bad PVD patients that you have to dilate. You cause pseudoaneurysms. You try multiple times. Again, that's not a criticism. Just in the heat of the moment, the technicality of the patient. Can't get all BMI 23 patients with perfect vasculature going on ECMO. Healthy people don't necessarily need ECMO. Sick people need ECMO. Sick people are technically challenging. So bleeding is the biggest thing, both from the fact that they get anticoagulation for the circuit and they have to maintain it. Sometimes your VECMO patients are on dual antiplatelet therapy. For other things, sometimes your people on ECMO already taking anticoagulation. I say bleeding is about 5 to 10%. Venous bleeding is easier to control. Arterial bleeding is a pain because uh, those are never going to go away with just manual pressure. It is a problem that needs a surgical repair.
Hmm.
So as the provider who's managing the patient after they're on ECMO, it's a group, your perfusionists, your primers, depending upon who, your ECMO specialist nurses are basically watching these sites, coming to you and saying, hey, this is my situation. And then for you as a provider, the decision is, can I stop anticoagulation, give them a chance? Do I need to put a stitch? If it's a vein in a nice purse string stitch, and just cinch the catheter down. Do I need to put a femstop? Not wrong. Putting a femstop just where the catheter enters the artery and just giving a little bit of pressure can be just enough. And then obviously correcting the coagulopathy. So these circuits can consume fibrinogen. You need to give them fibrinogen. You can give them tranexamic acid, Amicar. It's a very common problem in all ECMO patients, bleeding, not just from the ECMO cannulation, but from other sites, your tracheostomy, your bypass incision. So start with your anticoagulation goals towards basic repair strategies at bedside. Move towards replacing anticoagulants as needed. Remember, very dangerous thing to give someone FFP on ECMO because you can clot the circuit. So those are caveats that the ECMO specialist can walk you through it, but it's not like rocket science, man. It's very simple. Less anticoagulation, bedside control of it depending upon the situation, giving products based on what you think is safe. That's bleeding. Number one. Limb ischemia, bane of my existence. So limb ischemia is very common with VA. So, understand you're putting 15, 17, 19 French catheters that can go into someone's common femoral artery. That is, what is going down the superficial femoral artery? Nothing. You have to hope that catheters can have tiny amounts of blood go around them, and if you're already in low cardiac output state, what is going on? Nothing. So, at centers, we as a rule will put what is called as a distal reperfusion catheter. So, when we put the ECMO cannula that points up into the femoral artery, we will generally put a catheter that points down into the common femoral artery, and they basically both sit side by side like this, and they crisscross. And then we return blood down that catheter through your ECMO pump, so the blood flows down the leg. Let's say someone has a impella or ECMO on the other limb, we can put that and kind of create like a double limb where they're perfusing the legs. That's mostly a common strategy now. Some centers will only put it if they become ischemic, but that's more easy to manage than the bleeding perspective. It's not easy to put reperfusion catheters or those. Imagine you already put the patient on ECMO. There's nothing flowing through the catheter, right? The artery is completely empty beyond it. So how do you know that you're in the blood vessel after you put them on it? Right. Common femoral artery is zero flow. So it's a skill, but it's not that challenging. Then comes the infections. Catheter sites don't have to be completely perfect, but they have to be kept clean. Those incision sites can become infected. Someone poops on it, someone pees on it. Very common. That's usually more of an hygiene issue. Catching it early, antibiotics, and you decannulate them doing drainage. And now you come with the ECMO specific problems. Number one, embolism. Air can go from anywhere. If you look at centers, if you look at an ECMO circuit, there's a catheter taking blood out, going through a pump, then going through an oxygenator, going back to the patient. If you look at centers, we'll sometimes add CRT on top of that, add different circuits on top of that. There are so many breaks and side-ons that air can rupture and go into the catheter anytime. And that's lethal depending upon who the patient is. Very common feared complication. Some circuits have bubble detectors that as the blood is going back to the patient, if it detects a bubble, the machine just shuts down and then gives you as a clinician time to find out where the air is coming from. I've had catheters break, especially during COVID when we were running these circuits for 90 days, 160 days, where they were literally cracked. I've had catheters where the oxygenator cracked. We had situations where a pneumothorax caused air to leak. Somehow went to the drainage cannula, went back into the circuit, and then created a massive air embolism to the patient. ECMO specific. Hemolysis. Blood cannot come out of the body, go into the body without actually being damaged as it goes to the circuit. That's more of a problem because then you have to change the circuit, find a cannulation strategy. And then for VA, and I think that's where most centers have understand, you have to decompress the left ventricle. Let's say you put someone on ECMO for LV failure and you are injecting blood into the common femoral artery all the way up into the aorta. You're basically increasing afterload. So your ventricle that was already poor to begin with, for which you put on ECMO, how are you going to recover it when all it does is deal with more and more afterload? So you basically put a balloon pump, put an impeller, decompress them, and then obviously there are different techniques. Lava ECMO, upper extremity ECMO. They're all designed to allow the heart to rest. So some centers will not put physical pumps. Some centers will use just high dose inotropes like dobutamine or epi to chemically stimulate the heart to decompress. But that's again center dependent. So I think that's just a gamut of what I think are the most important complications you as a bedside clinician seeing ECMO for the first time should be aware.
Perfect. No, I think that's actually a fantastic overview. One of the questions that just popped into my mind, just listening to some of the things that you were talking about, it sounds like you've had ECMO circuits that have been for several months. You've had some folks, like the asthma example that you brought up, where, the individual was only on for 24, 48 hours, steroids kicked in. How do you make that call? Hey, I think this patient is ready to be decannulated.
Perfect. So actually, you actually opened up a Pandora's box, sir. Thank you. So let me go backwards. I think I missed a few things I should have said earlier. Define who you are in the spectrum. Is ECMO a rescue therapy where you only give it when nothing else fails? Is it a treatment when you give it when you're escalating the algorithm? Right? That is a very big line in the sand you have to draw because the question you asked me on when to decannulate feeds into this first question. Traditionally, why ECMO got a bad rep in adults was you gave it when they were in extremis, and then you took it out when they just came out of extremis. So basically, it's like when you have this line and you get up at, you go on ECMO, you go below it, you come off ECMO. But this doesn't take what is the disease process because this is a line for recovery all the way down here. So depending upon your center, and I think now I'm going to speak basically on my perspective. ECMO should not be considered as a rescue therapy. It should be considered as an active treatment to be given when you are early in the course and your other treatments have not worked. You don't wait for them to get refractory. That's, I think, going to be the big change in how we approach ECMO in the next 10 years. And the guidelines will follow. ECMO is early and not late. Then feeds to when you decannulate, right? Let's look at VV ECMO. Do you decannulate when their FiO2 is down to 40%? Do you decannulate when they're extubated? Do you decannulate when they're running laps around the ICU? Right? If I'm getting put on ECMO, let's say for any pneumonia, I want to come off ECMO and go home the next day. That is a benefit for me. That is a benefit for the system. I just went from a massive machine to home in 2-3 days. I went to massive machine to home, rehab the next day. That is a patient-centered outcome. What is not a patient-centered outcome? My FiO2 went to 70%. I came off ECMO, but I'm still tracked and pegged. Oh God, that's terrible. right? So going back, now you start that question, when to decannulate. When do you trial the patient off ECMO? When you pause the flow of the circuit, and again in VV, you don't turn off the circuit, you just turn off the oxygenator. Blood just runs out of the body and goes back into the body, but does not get oxygenated, does not have ventilation. So the patient's native lungs basically have to work. But then what do you define as the patient doing? Should the patient be extubated? Should the patient be in minimal vent setting? Should the patient be running laps? I like number three, right? So in my perspective, if I'm putting VV ECMO on a patient, I should be able to extubate them and then I should be able to rehab them, because the biggest thing is like if I extubate a patient and you've been through this in your patients who are not on ECMO, let's say you extubated an uncle, 60 years of age, came out of pneumonia, it's been 10 days, they're debilitated. It takes 20 plus days to get them walking because they have no strength. Why? Because their margin is this much. They only this much reserve. Can I take the same uncle without taking him off ECMO, rehab them over a week, get their nutrition up because they have unlimited oxygenation, and then take ECMO off? You basically give them a higher functioning starting point. So that is your weaning criteria. And if you look at, I think 2 years ago, again, I'm just speaking out of surveys because ECMO surveys are very important to us as centers, because when they do surveys of different centers, we get to see what our colleagues are doing. 1/3 of us will basically do what I just said, decannulate when they're functionally great. 1/3 of centers will decannulate when they're borderline, and 1/3 of centers will decannulate when they are just reaching basically normal vent settings. But then they have the whole process of extubation or trach and decannulation to go. Can I do this all the time? No. There are patients who are like severely encephalopathic. COVID encephalopathy was a big example. It took weeks to break that mind agitation. You have to trach them. Then you have to walk them. So if patients are having bleeding complications, their patients having infectious complications, that speeds up our need to decannulate at a higher level, not necessarily them walking around. So that's your VV patient. When they're ready, I'd prefer when they're extubated and able to participate in rehab, confirm that they can participate in rehab at a good level and then decannulate.
Perfect.
If they're not, trach, do trach collar, make sure they're not on like vent or CPAP, like an obese 65-year-old. I'll take the BMI of 70, put them on PAP therapy because that's literally what they need, because that's 90% of the problem. Make sure they're tolerating PAP therapy, decannulate them from ECMO, and then walk them around. Such an easy thing to do when you're like seen this over and over again. VA, different. So I think the world of VA has changed a lot, Irtaza, because we've not spoken about PEs and RV failures because there is such a eclectic field that it's going to take 2-3 hours to talk about those. Let's talk about a garden variety LV failure. For we had to recover, or you had to go on upper body ECMO. So what you call a sports ECMO, where you do it up surgically put a catheter so the patient can walk, get them to a transplant, get them to an LVAD if they're not recovering. Today, because of the Impella 55, I think the Impella 55 has put a lot of options on the table when a patient, because remember, when you do ECMO on the ED for cardiac arrest or for cardiogenic shock, these are all emergent VA ECMOs through the lower extremity vasculature. Let's say they recover, you take it off, all good and well. They don't recover, you need to think of transplant, LVAD, or Impella 55 now, because that can go up to 6-7 liters of flow on the LV, and it's done from the LV itself. So now we will go from VA ECMO and a balloon pump or an Impella CP as a vent to an Impella 55, take everything off, and then rehab them, walk them around. And then look at bridge to recovery, bridge to transplant, bridge to LVAD, if it's purely LV. So for them, decannulation is becoming faster and faster, because if I put someone on VA ECMO, I want their kidneys to recover, their liver to look better because of their shock liver. I want them to be extubated or have no pulmonary edema. Put them to a 5-5 if they don't recover, and then do the next part of the algorithm. So VA ECMOs are much shorter runs today because of the other devices that we have.
That
Makes sense?
No, perfect. And I think it hopefully answers a lot of questions that folks have. All right, so when is somebody actually ready to come off ECMO? And I think that was actually a great overview. So, kids, as time is running low, if I put a gun to your head and said, hey, listen, we've had, half an hour plus conversation. If I'm a first-time listener and I'm listening to this episode, what are some high-yield key takeaways that I can take away from this episode?
Okay, sure. I'll minimize it. So let's talk VV. Who do you give to respiratory failure? When do you do it? PF ratio less than 80, refractory hypercapnia. How early do you do it? Less than 7 days preferable, but time is relative. Talk to your center. What age? Again, relative. Should you have a reversible disease? Probably. You don't want ILD or something unless they are already listed for transplant. Where's this information coming from? Caesar and Eolia trials should read them. It's been about 7 to 8 years for the last one, but they've influenced our decision making. Problems: bleeding, infection, hemolysis. That's your VV and ACAS. And again, highly recommend reaching out to your centers, talking to the coordinators, asking them what are the inclusion exclusion criteria, because your geography will define who you can and cannot based on the appetite of your referral center. If you're in a center where ECMO is, if you're a resident and your intensivists do it, your cardiothoracic surgeons do it, cardiologists do it, ask them how they approach VV for that perspective. VA, who do you do it? Mostly cardiogenic shock, cardiac failure, LV, RV, both. How do we do it? Usually in the femoral veins and arteries, but there are other variables too. When do you do it? When they are in refractory nature or they are in extremis about to arrest. Sky D, Sky E, the lactates are rising. Who don't you do it on? Patients who are either prolonged arrest, downtimes are long, patients with disease processes that you can't fix with ECMO. What is that? A patient with type A dissection, severe aortic regurgitation. Is there a consensus to where you draw the line in cardiogenic shock? Not yet. Is it all clinical gestalt that chooses who goes on ECMO? Yes. Is it like VV ECMO where you can put age and everything into the package? Probably not. I'd probably use a frailty score. Problems specific to VA ECMO: limb ischemia, very common. Distension of the left ventricle because you've not unloaded, very common. And then every textbook, and I forgot to tell you, every textbook likes to talk about north-south syndrome. It's fun to talk about, but almost rarely seen, right? We unload the LV so well that you will not see north-south syndrome anymore as much. ECPR. Who do you do it on? Refractory cardiac arrest. Predominantly VTVF. You can do PEA for patients with PE, but to prove a PE in the out of hospital is almost never possible. In hospital, a little bit easier. What do? You provide perfusion before you can revascularize or fix the primary problem. And things has to be bystander. CPR within 5 minutes has to be witnessed. Arrest to ECMO time has to be 60 minutes or less. Do you have data supporting that? Yes, we do. Is it going to get better? Sure. Caveats: history is never appropriate. How many times have I put people on ECMO that turned out to be congenital heart disease or pacemakers up the wazoo or missing limbs? So that's my big red flag with ECPR, is the ability to get data before you put them on is almost abysmal, and I don't think I have a solution for that yet. What is the recovery potential? Not the best. I forgot one thing. Bridge to donation can exist in these situations too. So it's another day, another conversation. But that's kind of your summary for VV, VA, and ECPR.
That's awesome, man. Thank you so much for your time, man. I
Oh,
really appreciate it. And before I kind of let you go, I was going to ask you, is there something that I didn't ask you that you'd be like, hey, man, this is like my ECMO soapbox that I want to say before I go? Because again, it was hard for me to get you on here. It took a couple months, but now that I have you on here, man, is there a soapbox that you want to get on about ECMO and just, let the people know, let the world know?
I think you have to be, so don't be scared. I think my first ECMO candidation I saw as an intern or a resident was in my third year. That's 2015. In 10 years, from basically seeing ECMO like, oh, something's happening in the corner, and there's like a crowd of like 20 people watching, to today, and you see most centers are just another day for us. It's becoming more and more common it's not a bailout option, it is a regular option. Your centers are going to be doing it on a routine basis in 10 years. As the technology for the circuits become easy, the technology for oxygenators become smaller, you are going to be doing it, whether you like it or not. Don't be afraid. Get used to it. It's just another learning curve. Start getting tuned to it, because I think as you become more adept in who does well and who does not, you'll start seeing it in community hospitals. We see impellers in community hospitals now all the time. They did a good job of rapid upscale, rapid use, good data to prove it works. ECMO just fell behind because we're like privileged people, and the industry is different. ECMO doesn't have much industry behind it in terms of like impeller and all these other devices. So
Just wait till the Hollywood movie, man. Wait till the Hollywood movie and the industry will come. Don't worry.
I think I saw it on one of my wife likes seeing that, the pit show.
Yeah, oh
And I saw
yeah, that's true.
oh my
That's
God,
true. I did see a lot of Reddit posts afterwards, and they're like, "Oh man, just put me on ECMO. I'll live. Doesn't matter." And I'm like, "Well, I don't think this is the right idea here, but that's okay. It's got to start somewhere, right?"
it made it to a popular show. There's different caveats. You know, understand the world of ECMO is going to be different, and yes, you're going to be a part of it. Whether you're the cannulator, whether you're the management as an intensivist, whether you're the management as an ER physician when you cannulate in the ED, ER physicians are cannulating. The biggest thing is inclusion criteria is important because ECMO can put a person between life or death, and then you can be stuck there if you choose the wrong patient. And trying to manage patient who's stuck in that without no exit is one of the hardest things to do as a provider because it's a very emotional event for most people. So get used to it, know the criteria to go on, be comfortable with it, have a mature system where you as an ED or an intensivist or a resident understands what the hospital protocol is, because it's a very, whether you're VV, VA or ECP, or each of them have their own activation protocol, providers, teams. See how these teams work, see where you can gel in, because if it's going to be a part of your life in 5 to 10 years every other day, don't get afraid of it and get acquainted with it today. Fair enough?
No,
Goodbye,
that's a banger closing, man. That was what I wanted. I was like, put you on a soapbox, let you go, man. No, that was awesome, man.
message.
Hey, if anybody has questions out there on ECMO or they wanted to pick your brain about it, is there a certain place where they can connect with you, reach out to you for questions?
Email, and we can correspond depending upon a call. I think email and phone calls are easy, but I think
Cool.
email me if you have any questions, and we can take it from there.
Perfect.
That's easier.
Awesome, man. And I'll drop your email in the show notes. And for anybody that wants to reach out to you, connect with you. This was a fantastic episode, man. Lots of amazing takeaways. And again, like you pointed out, ECMO isn't magic. It's not a cure. It's a bridge. It's a bridge to recovery. It's a bridge to a decision. And sometimes a bridge to a totally another level of care, whether that's transplant or something else. But the patients who benefit most are usually recognized early before the spiral typically becomes irreversible. So whether you work in a community ED, a tertiary care center, the ICU, pre-hospital medicine, really just understanding how this works at some level is really how we start the conversation. Because in modern resuscitation, it's no longer just about pushing harder. It's about recognizing when conventional therapy is failing and knowing what systems are out there and that exist beyond it. A huge thank you to one of the best mentors, or actually the best mentor that I've had in my career, Dr. Hitesh Gidwani, the leading expert at ECMO science in the country, for joining me on this episode and helping break down one of the most fascinating and rapidly evolving areas in critical care and resuscitation medicine. If you enjoyed this episode of The Learning Curve, make sure to subscribe, leave a review, share it with somebody else in emergency medicine, critical care, or resuscitation who might find it valuable. And as always, stay curious, keep learning, and we'll see you next time on The Learning Curve. Thank you so much, man.